And we're live in 5,
4, 3,
2,
1.
Good morning, everybody. Today, I have the immense pleasure of introducing Dr. Joshua Kamins for our Grand Rounds talk. Dr. Joshua Kamins is an associate professor of neurology at UCLA and an associate director of the Steve Tisch Brain Sport program. He graduated from the University of Pennsylvania and received his medical degree from UC San Diego. He then returned to Southern California to train in neurology at UCLA. At UCLA, Dr. Kamins found a way to unite his interests in sports medicine and neurology by becoming the first neurologist to complete fellowships in both headache medicine and sports neurology. His current research interests include investigating treatments for post-traumatic headaches and improving the diagnosis of concussion, while his clinical interests consist of primary headache and facial pain disorders, post-traumatic headaches, and persisting post-concussion symptoms. Welcome, Dr. Joshua Kamins.
Thank you so much for having me. Okay, well, thank you for that wonderful introduction. Let's get started today to talk about post-traumatic headache and persisting post-concussion symptoms. My only financial disclosure that's relevant is I've served as a consultant and at times on the speaker bureau for Lundbeck. So let's start by reviewing concussion. This is the 2023 updated diagnostic criteria for mild TBI from the ACRM. I was on this task force, and our goal was to develop sort of the new gold standard definition for concussion. Hadn't been done in 30 years. We wanted a stringent definition, one that erred on the side of specificity over sensitivity. And from a research perspective, this is useful because if you're trying to design biomarkers or imaging tests, you want to be sure that you're looking at the disease that you think you're looking at. Clinically, it's useful to determine who definitively has a concussion versus those who may need a wider differential. So we expect actually a lot of suspected concussions end up being managed as concussions. Essentially, the first criteria is the most important, that there's a plausible mechanism of injury, not that someone was just in a car accident or that they played a football game, but there was a sufficient force to the head to cause an acceleration-deceleration injury. And once that's satisfied, then there's a few different ways to get to traumatic brain injury. First would be probably the easiest, which would be one or more clinical signs of concussion. That can be loss of consciousness or amnesia, observed confusion, an impact seizure. One of those gets you there. In addition, neuroimaging abnormalities that are consistent with TBI, although in concussion, that's not going to happen, but in other traumatic brain injuries, including complicated mild TBIs, you may see neuroimaging abnormalities that are intracranial neuroimaging abnormalities that we see in TBI. And lastly, probably the most common way is that patients have symptoms, right? But the problem is that symptoms are very non-specific. When we were doing our research, the likelihood of having a headache after hitting your head is pretty high, but the likelihood of having a headache after hitting your head wasn't specific enough to say that it was a concussion. So we wanted 2 or more symptoms. Again, not just a single symptom, but in addition, something observable and objective, something on the clinical examination that showed that there was brain dysfunction. And then we left room also for laboratory findings. If you'd asked me a few years ago, I would have said we're far away from having consistent lab findings in concussion, but I think we're actually really close to prime time. And then if you only have, say, the symptoms or the lab finding or exam findings, then we would call it a suspected concussion. Or if you met the criteria, but there were confounding factors that made it a little unclear, for example, alcohol intoxication, then we leave room for suspected mild TBI also. Biologically, what's happening? Well, we go back to the neurometabolic cascade of mild TBI that my mentor, Dr. Giza, sort of made his career on. And it hasn't really changed much. We've added to it a little bit, right? But the essential injury is that of an energy problem. So after this sufficient acceleration, deceleration injury, you get stretching and mechanoporation of the neurons. You get this massive ionic flux, calcium rushing in, potassium rushing out, sodium rushing in. The sodium-potassium pumps are going into overdrive to sort of deal with that. That ionic flux leads to glutamate release at the synapse, resulting in cortical spreading depolarization and more ionic flux, and sodium potassium pumps have to, again, further try and make up for this issue. And so you get hyperglycolysis to provide the ATP for these pumps. And eventually you get glucose depletion, you get ATP depletion, and concurrently there's cerebrovascular reactivity dysfunction. And so you get decreased delivery of those nutrients. And this mismatch between the neuronal demands of energy and cerebral glucose and cerebral blood flow delivery leads to neurovascular decoupling or metabolic mismatch. Subacutely, there's upregulation of inflammatory cytokines and pain neuropeptides. And in some patients, there's cytoskeletal injury, which at the more severe end results in actual axonal injury or dysfunction. The biggest change, I think, in the last 20 years of concussion is the acute management. We used to say, rest until you feel better, right? And what we understand now is actually that early physical and cognitive activity may be beneficial for patients' recovery. That if you take a healthy teenager and you say, oh, rest until you feel better, don't leave your room, don't look at lights or sounds, don't look at your screens, don't interact with your friends, they don't actually tend to get better, they tend to get worse. And so we have some data that shows that. This pediatric study from about 10 years ago looked at 4 quartiles of patients after concussion, and those who had the least amount of activity, and those who had the most early activity did the worst, and everyone else in the middle did the same. And then in a more controlled trial the next year, Thomas et al. Showed that if you took patients after concussion and then gave them 1 to 2 days of strict rest and compare that to kids who you gave 5 days of strict rest to, the kids who gave 5 days of strict rest took 3 days longer to recover. And during the time that they were recovering, they had a higher level of symptoms. So current management is not cocoon therapy. Instead, maybe strong rest for 1, 2, maybe up to 3 days, and then followed by graded cognitive and physical exertion. And how long does a concussion last? Well, there's a number of studies. I like this 5P study. Again, it's a pediatric study, but it does allow us to extrapolate to adults. Essentially, kids took about 2 weeks to recover on average. If they were adolescent, it was closer to 4 weeks, and female adolescent patients took a little bit over 4 weeks. And then adults, if we look at some of the care studies and kind of older adult studies, they look a little more like the earlier kids, so about 2 weeks recovery time. And if we know who's going to take longer, then we know who we can intervene on, who we should be paying extra attention to, and maybe initiating treatment a little bit earlier. So that same 5P group found a group of risk factors for prolonged recovery. I think the biggest one to me is a really high symptom burden acutely. So if the symptom score that you get right after concussion is 80, even 100, which we can look at that symptom score later, that's suggestive of someone who's going to have a little more trouble recovering than someone who had just a few symptoms. Adolescence seems to be a risk factor. Female sex seems to be a risk factor. Prior prolonged concussion recovery, which makes sense. Personal history of migraine, certain acute symptoms, including headache and phonophobia, and a high score on the balance error scoring system. Other studies have found that, similar to other types of injuries and pain, low socioeconomic status, poor pre-injury resilience, low cognitive reserve, and then specifically to concussion, a premorbid history or even a family history of certain disorders that we see the symptomatology of in post-concussion syndromes, such as headache or migraine, depression, anxiety, learning disabilities, and ADHD. About 80% of patients recover within that month. So we say about 10 to 30% of subjects experience persistent symptoms beyond a month. We really stopped using this term post-concussion syndrome because there isn't a single syndrome, and it implies that the concussion itself is still responsible. So we then moved on to the term persistent post-concussion symptoms, and more recently, people have been adapting persisting post-concussion symptoms, or PPCS. Headache is by far the most common acute and persistent symptom, followed by mood changes and cognitive dysfunction. Somewhere between 12 and 44% of patients with PPCS will have depression and or anxiety. But once we're in this chronic phase and we see symptoms like mood changes, dizziness, cognitive symptoms, headache, sleep disturbance, and what I think the kind of new frontier is autonomic dysfunction, what we want to start doing is separating these symptoms from the initial injury. That these are sequelae of the injury, but not an ongoing concussion. The analogy I give to my patients is, take someone who sprains their ankle. 6 months later, if their ankle still hurts or their knee hurts on the same side, we don't brace that ankle. We know that the pain in their leg 6 months later is because they developed an abnormal gait, or the nerves got sensitized, or they had overuse injury in adjacent muscles. And so we don't treat that initial injury, rehab the sequela of it. And we should do the same in traumatic brain injury. Interestingly, there was a study about 20 years ago that looked at if you diagnose post-concussion syndrome just based on symptoms, there was almost the same likelihood of having post-concussion syndrome 3 months after a mild TBI as there was after a orthopedic injury, suggesting a lot of these symptoms are not specific to the concussion itself, but rather to injury recovery and the disruption to life that injuries bring us. So let's dive into headache specifically, because that's my favorite part of this. Headache is the most common acute and, like I said, also persistent symptom after a concussion. A post-traumatic headache represents 4% of all secondary headache disorders, although it can coexist with others like medication overuse headache. It generally resolves, like all concussion symptoms, within a month, or especially within 3 months, but up to a third of patients with post-traumatic headache end up with symptoms beyond 1 year. Phenotypically, it looks most similar to migraine, some like tension type headache, and really rarely to the trigeminal autonomic cephalgias. This is the definition according to the ICHD-3. This is like our headache Bible. And so basically, it's not that surprising. You need a sufficient injury and to headache to start within 1 week. If the symptoms are there for less than 3 months, it's considered acute. And for more than 3 months, it's going to be considered persistent. I think there will be changes in ICHD-4. Personally, I think that line of acute versus persistent should probably be closer to 4 weeks, maybe 6 weeks. And the big debate and argument we're going to have is when the headache has to start. Really, 90+% of patients have symptoms within 48 hours, and especially within 72 hours. So I think the 7-day mark personally is a little bit long. But not all post-traumatic headache is created equal. This is a paper out of the Four Corners Youth Consortium that we published showing that adolescents who had headache after the concussion took longer to recover than those who had no headache. But those who had a migraine-like post-traumatic headache took even longer to recover than those with simply a tension type or non-migraine-like post-traumatic headache. And interestingly, our female subjects were more likely to be in the post-traumatic headache with a migraine phenotype group, suggesting that this may explain some of the sex differences that we see in concussion recovery. One other interesting part of post-traumatic headache is this high rate of continuous pain or continuous headache. It's something that we see a lot and hasn't been studied very much. Alan Finkel looked at this a few years ago, and in his military cohort, no matter if the headache looked like a tension type headache or migraine, 75% of the subjects reported continuous headache. And what I don't quite know, and the field doesn't know, is this a marker of something unique to post-traumatic headache, or just a marker of the fact that post-traumatic headache is really hard to treat and really refractory, and that this is just a more severe headache than most patients with migraine, for example. So then let's talk about treatment and how that applies to the physiology of headache. This is a sort of theoretical algorithm from a paper I wrote a few years ago, a review. It represents the ideal in my mind, some things that we just don't have the evidence for to concretely say, but how I organize it in my brain and what I expect things to look like as the evidence starts panning out in the next few years. In overview, after concussion, you initially utilize acute management of concussion. You determine who has other injuries like neck pain that might be separately treated. You want to differentiate high versus low risk of persistent symptoms and treat the patients with high risk of persistent post-traumatic headache a bit more aggressively, utilizing acute medicines when appropriate, and then in certain individuals, instituting preventive medicines on the earlier side. And always evaluating for multidisciplinary needs: neuropsychology, physical therapy, occupational therapy, and clinical psychotherapy. In terms of the acute post-traumatic headache, again, traditional TBI management to start. As needed medicines are okay. You don't have to worry that there's a bleed after we know that it's going to be a concussion. So using NSAIDs and other things that may increase risk of bleed are not an issue. And there was this idea for a while that you didn't want to mask symptoms because maybe they would push too hard if you mask these symptoms. But now that we know that early physical and early activity actually improves recovery, I think reducing symptoms early so that patients feel comfortable moving and starting to do activity earlier is actually beneficial. In addition to the medicines, though, acute rest and then subthreshold exercise and graded return to activity, looking at multidisciplinary needs, like I said. We mentioned differentiating high versus low risk of persistent post-traumatic headache. The data here is unfortunately pretty murky. There's more data on concussion in general and less on headache specifically, but again, high symptom burden, personal or family history of headache or migraine disorders, post-traumatic headache with a migraine phenotype as we saw. Those are things that I'm going to take into consideration about who I want to treat a little bit earlier. And then we want to treat those high headache burden patients and high risk for persistent post-traumatic headache aggressively. Break the headache cycle, get ahead of the pain, look at multidisciplinary needs, try and figure out who's going to be pretty avoidant and who might need extra resources like psychotherapy or OT really early on. How about evidence? Well, there's not a lot. There are these two studies that came out of the emergency room. The first from Friedman in 2018 found that intravenous metoclopramide and diphenhydramine, if given in the ER to patients within a couple weeks after concussion, 20 out of their 21 subjects reported headache improvement to no more than mild at time of discharge, but a quarter of them had relapse of their headaches within 1 week. And then Stephen Chan in his emergency room performed a retrospective study of 250 kids and adolescents between 8 and 21 years of age. They had mild TBI and headache within 2 weeks of their injury. And if they had one or more likely more medications, including ketorolac, metoclopramide, prochlorperazine, chlorpromazine, or ondansetron, 86% of them had treatment success. But over half of them reported complete resolution of at least their headache in the ER before discharge. So we know that the medicines that we use generally for headache work acutely. It doesn't necessarily prevent them from having recurrence of their headache. But besides this, there's no clinical trials for NSAIDs, triptans, gepants, steroids. And some may say, well, if most recover, why worry so much about acute treatment? And to me, it's well to reduce symptom burden acutely, partially because I think that will help them recover more quickly. If they have a lower symptom burden and earlier activation, they'll do better, like I mentioned. But also, we don't avoid symptomatic treatment of other time-limited diseases. We don't not treat fevers or pain when we know that it's going to be temporary. So I'm a big proponent of early treatment. Can we target that physiology that we talked about earlier? There's that metabolic change, that metabolic dysfunction. Well, I'm looking at creatine as a treatment early on. Other people are looking at ketones. We know that glutamatergic surge that happens with that cortical spreading depolarization is an something early we can identify, leads to activation of the trigeminal vascular system, which we know is similar to migraine. So can we block glutamate? Well, topiramate sort of does that. It's an antagonist of the kinase subtype receptor, but not a great medicine for people with acute concussion, given the brain fog. So I like magnesium early, just like in migraine, and I think memantine is going to pan out as maybe an early treatment that we can use in concussion. And then we have the pain neuropeptides. There's CGRP, which we're going to talk a bunch about, and there's PACAP. There's other pain neuropeptides like substance P and some other ones that are coming out. What do we think about those? Well, like in the rest of the headache world right now, CGRP is likely the common denominator, right? There's some early studies that showed elevated levels of CGRP after concussion. Elliott et al. Found that after a CCI mouse model, there was significant reduction in periorbital pain thresholds, increased photosensitivity in the animals, and this correlated to increased CGRP immunoreactivity. And then a follow-up study by the same lab, Diatulo et al., again, CCI model, CGRP again elevated in these animals. And if you gave sumatriptan or a CGRP antagonist, it actually reduced those pain thresholds that had been increased in the previous study. So both studies suggest CGRP is not only elevated after a TBI model, but at least partially responsible for the symptoms that we see. There's been some wonderful follow-up studies. So this is a paper out of Mayo Scottsdale by the Frank Parekha lab, Navratilova et al. Mouse concussion model. If they gave a CGRP monoclonal antibody 2 hours and 7 days after the injury, they blocked this allodynia that they could trigger with bright light stress. But if they waited until day 10, when actually the allodynia had calmed down, to give the antibody, it did not prevent the bright light stress triggered allodynia. So it suggested that early treatment or early blockade of CGRP may be more important than delayed treatment once the maybe central sensitization or peripheral sensitization has kicked in, potentially suggesting a mechanism of differentiating early versus persistent post-traumatic headache. So then what do we do about acute post-traumatic headache? Well, given the overlap of symptoms with CGRP-mediated diseases like migraine, number of papers showing acute CGRP elevation in animal models, and that targeting this in animals at least reduces symptoms, I think we should be considering targeting CGRP early with things like CGRP antagonists and monoclonal antibodies. Triptans also reduce CGRP, and then actually, weirdly enough, NSAIDs and steroids do as well. And yet, CGRP isn't everything. We need to understand this mechanism of sensitization that we keep seeing. The Brian-Levy paper had a rat model of mild TBI, and they showed that these rats developed cephalic pain hypersensitivity after their injury, and that it went away within a couple of weeks. But if you gave them sumatriptan or a CGRP antibody, it ameliorated it much sooner. But then once the sensitivity went away, if they gave them a traditional migraine trigger like nitroglycerin, it renewed that pain sensitivity. And that was, again, inhibited by sumatriptan or a CGRP inhibitor. So it shows us a little bit more than maybe some of those migraine-like triggers, those sensitivity to triggers in the acute post-traumatic headache time frame might be CGRP mediated. But because there's a gender bias in so much of science, they realized this, and then they went back and did the same study in female rats, which is not done nearly enough. And compared to the male rats, the female rats took longer to recover from that cephalic hypersensitivity. They had increased responsiveness to the headache triggers and decreased effectiveness from the anti-CGRP treatment, and more significant elevation of CGRP post-injury. So the authors hypothesized that, at least in these female rats, there might be differences in CGRP pathways and central pain pathways and additional forms of central sensitization that we aren't seeing in the male rats. So in summary, for acute post-traumatic headache, I think you want to consider breaking that headache cycle early if the headache burden is high enough, using things like oral steroids, non-steroidals, long-acting triptans, and especially in my mind, well, triptans are included in my mind in CGRP inhibitors actually, but the CGRP antagonists, perhaps antibodies early on if we have evidence. And then I tend to actually use a lot of peripheral nerve blocks if I'm able to, because I think that's useful in the acute time frame also. And then in these really high-risk patients, we want to consider maybe physiologic specific preventive treatment, NMDA blockers like magnesium or memantine, or even CGRP antibodies. If we move on to persistent post-traumatic headache, and we try and use that same model, target the physiology, it's a bit harder. Part of this is because it's just easier to study acute physiology better, and we haven't had the studies in long-term post-traumatic headache in the same way. But also it's a different disease. There's different biology. So that energy mismatch issue has resolved. The inflammation is likely resolved. The concussion itself is sort of done. Cerebral autoregulation is coming back to baseline. And then, but on the other hand, central sensitization and pain pathways and pain neuropeptides have changed, and those have set in. We know that the clinical features of post-traumatic headache look most similar to migraine or sometimes distension type headache. And based on some animal models, you see CGRP dependent and independent mechanisms. You see persistent alterations in glutamate receptor subunits. There's persistent hypothalamic perturbations. Other pain neuropeptides are altered, like BDNF and PACAP, as we're about to look at. But there's really yet to be a unified theory of pathophysiology. Clinically, a common feature that we notice is this hypersensitivity to headache triggers Patients with post-traumatic headache report a lot of light sensitivity, small bumps to the head re-trigger all of their symptoms. And if you look at that Brie and Levy paper, we saw that maybe some of that at least is CGRP mediated, but that not all of it. So from the basic models, at least, it looks like there's a lot of potential areas of mechanism or area of study. There's neuroendocrine, there's pain neuropeptides, there's pain sensitization in general. Some of the more recent studies, though, I think have done this amazing job of trying to compare post-traumatic headache to migraine, because this is a model of a disease that we know how to treat pretty well. And so the Danish group have this amazing ability in migraine and now post-traumatic headache to take some biology and translate it from animal to humans. And so what they've done is they've taken pain neuropeptides or other chemicals that we know are involved in headache and infused them into patients with the disease and look at what happens. And if you infuse CGRP into patients with persistent post-traumatic headache, 70% of them develop a headache with migraine-like features within a few hours, as compared to 20% where you just infuse a placebo. So this, to me, strongly suggests that CGRP plays a big role in post-traumatic headache, even in the persistent realm. And then the new kid on the block you may have heard about is PACAP. PACAP is another pain neuropeptide involved in migraine. If you infuse it to patients with migraine, they also get a delayed migraine. And so in post-traumatic headache, if you infuse PACAP, just like the CGRP, into patients with persistent post-traumatic headache, they 90% of them get a migraine-like headache within 6 hours, as opposed to just 10% of participants with placebo. So even stronger than CGRP, if possible. And PACAP tends to come along with more of those prodrome symptoms. We see that in the migraine world too, and more of the autonomic features. So it might not match some of the same symptoms as CGRP. Maybe it's less about pain and more about the other stuff. There's some additional trials coming out from the same group, and they're trying to really narrow down this physiology. CGRP and PACAP channels, when activated on smooth muscle cells, increased levels of cyclic AMP, and so downstream they open other channels. One is the BK calcium channel. So if they open that in patients with persistent post-traumatic headache, they do the same thing as in the previous trials, and they infuse something to open it. That also triggers a delayed headache, not quite as strongly as PACAP or CGRP, but at least in, I think, half to 2/3 of subjects. And similarly, certain ATP-sensitive potassium channels are downstream from both of these receptors, and if you open those, similarly it triggers a migraine-like headache in patients with post-traumatic headache. So I think we're narrowing it down. There's this common pathway between CGRP and PACAP and the downstream effects of it, and that seems to play at least a big chunk of the role of persistence of the headache. Any treatment data in the persistent world? There's a little bit. It's starting to build. It's pretty sparse. There's a couple studies on Botox or botulinum toxin, which have shown efficacy. Melatonin looked promising initially. There was a pilot trial that looked positive, but when they did a larger RCT, it was negative. There's a couple studies on tricyclics and gabapentin, but they're pretty heterogeneous populations and not the best controlled, so we can't get a ton from it yet, although they're great early studies. And so if you look at the kind of the newest things that we're talking about, CGRP, there was this open label study on Neurometabolic for persistent post-traumatic headache, and it really looked positive. A lot of people got benefit, a lot of people stayed on the drug, but then subsequently we had a negative Preventive study 2 years ago. The other CGRP antibody companies are thinking about it. From what I hear, they're sort of dipping their toes in the water, but there isn't any concrete plans, although there is a military study for Neurometabolic again ongoing. So I'm hoping in the next couple of years we'll have some more concrete post-traumatic headache treatment studies coming out. But the current recommendation, because of this lack of evidence, is to treat post-traumatic headache like the closest primary headache syndrome looks like. If it looks like migraine, treat it like migraine. If it looks like tension headache, treat it like tension headache, etc. And so from that perspective, how do we treat headache? Well, just run through how I think of headache. We have our acute or as needed medications and our preventive medications. We're in the golden age of headache treatment. There are so many options these days. If we really focus on the preventive treatment of headache, which I think is a little bit the more challenging part of things and the more valuable to focus our time on in this population, we have a number of options. We have our nutraceuticals, we have our antihypertensives, antidepressants, anticonvulsants, and NMDA antagonists, CGRP inhibitors, both CGRP antibodies and small molecule antagonists. We generally in the headache world pick them based on side effect profile, ones that we like and ones that we want to avoid. Personally, in this population, I use a lot of tricyclics, nortriptyline. I use a lot of duloxetine, memantine, CGRP inhibitors, and botulinum toxin. Because we're talking about concussions, we want to be aware of the patient population we're looking at and the medication limitations in that group. We generally want to be careful with AV nodal blocking medications like beta blockers and even calcium channel blockers, which can affect athletes. A lot of my patients with concussion are athletes, and so we don't want to decrease their cardiac output and limit their exercise tolerance. There's certain substances that are banned in sports. So in sports where you need like really steady hands, beta blockers are actually banned, like archery and golf. Racing sports also often ban beta blockers. I think it's banned in NASCAR. We want to treat patients with as little medicine as possible. And so we want to utilize medicines with multiple benefits, but then also be aware of things that we could exacerbate. So look at their comorbidities. So we may want to avoid topiramate in this population where cognitive dysfunction is so common. In patients with autonomic dysfunction after concussion, we want to avoid medications that can exacerbate it, like tricyclics or SNRIs. And we may want to use medicines that can kill two birds with one stone. So if I have a patient with a lot of depression, duloxetine might be something I reach for. Or if I have patients with cognitive dysfunction after concussion, memantine might be something I reach for. Non-pharmacologic treatment is always important in the headache world, but especially in this patient population who tend to be a little more sensitive to medication side effects. And so I tend to focus on consistency, consistent sleep, consistent regular exercise, nutrition, including consistent caffeine intake, either all or every day or not at all, and a strong focus on mental health. We have our neuromodulation or neurostimulation devices that are out there, and they're increasing all the time. Supraorbital nerve stimulator, TMS, single pulse TMS devices, the vagal nerve stimulator, the remote electronic nerve stimulator. There's now the supraorbital and occipital nerve stimulator, number of devices out there. And I find them really helpful as sort of an adjunct therapy to have on those days, especially for patients with continuous headache and they need to combine, they're sort of running out of their acute meds. It's really helpful to have a device to have as well. And then it's always important to remember that headache is not always just a headache, that these are patients who had a big, acceleration, deceleration injury to their brain, but that means their neck may also have that same injury. So whiplash is really common, and I see a lot of patients who are sent to me for persistent concussion symptoms, and I talk to them and I think, I'm not even sure they had a concussion, but they had a whiplash disorder and they have headache because of that, and they have trouble sleeping and anxiety and depression from the whiplash and cognitive dysfunction because of that. So really focusing on the neck and understanding how it plays a role in the headache is important. I don't always love the term cervicogenic headache. We are neurologists. We should be good at localizing the lesion. And so if we just say cervicogenic headache, it's not always that specific. Knowing that the majority of patients actually who come to you with neck pain along with their headaches just have a headache disorder. 2/3 or up to 3/4 of patients with migraine have neck pain as one of their first symptoms of their headache. That's just because the trigeminal system dips into the cervical spine. Other patients might have myofascial pain or tendinopathic pain. There's a lot of facet dysfunction after whiplash injury. There's discogenic pain, and there's occipital neuralgia. This pain might be occipital, but even can radiate forward. We know that the C1 DRG, when stimulated, actually radiates to the retroorbit or the periorbital region. And so I tend to use the exam to try and differentiate these and try to figure out if there's a primary headache or secondary headache disorder versus an actual neck injury. And then, like I said, mental health plays such a big role in these patients. And we know from the primary headache world that psychological treatments are useful at reducing symptom burden and improving quality of life. CBT specifically has been shown beneficial for kids and adults with migraine, augmenting the efficacy of standard medications. And I think that's because pain and mood is sort of bidirectional. Patients with chronic pain have a high rate of depression. And sometimes when they develop depression from their chronic pain, that's actually what ends up being the most disabling part of it. But also people with high levels of anxiety and pain catastrophizing and depression, and therefore other things that come with it, like insomnia, those things can all exacerbate the pain as well and make it harder to cope with being in pain. And that leads me to some of the common comorbidities in the persistent post-concussion world and post-traumatic headache. It's not all just headache, as much as I'd like to pretend it is. But one of the number one things that I do in my clinic is reassurance. A lot of cognitive restructuring and trying to get people back to their normal life. So we see a lot of avoidant behavior. After the acute period, there's not any benefit of rest, and in fact, it's counterproductive. So there's this old adage where, essentially, if you go to work one day and you have a headache and you avoid work the next day because you have that headache, and the result is therefore no headache, what are you going to do? You're not going to go back to work. You're going to avoid that activity. It's totally logical. But when you start avoiding all of the triggers of your symptoms to feel better, eventually you have nothing left in your life. People pull out of school, people pull out of work, physical activity. And in the end, that doesn't reduce their symptom burden. What it does is leave them nothing to distract them from their symptoms and nothing to give their life purpose and to take their life focus away from the symptoms. And so then all they have is their headache and their other ailments to focus on. So one of our biggest jobs is try to convince people that when they get symptoms, when they get a headache, and it is disabling and it feels terrible, that it's not damage, that nothing bad is happening in their brain, especially after that first week or two, that this is a sign that they need to pay attention to, but that they don't have to worry that something is happening. And I can't tell you how many patients, that's all I had to do for them, because there's something that's reinforcing about this that really magnifies symptoms. And when people know that they're allowed to just live their life, and if they have a headache, it sucks, but you get to treat it and move on, that nothing bad is happening, that really relieves a lot of people's symptoms. So we want to, again, teach avoiding avoidance. And part of this is because there's this enhanced anxiety and fear circuitry after concussion. We know in our military population that those who had a brain injury at the same time as an emotionally traumatic event have a higher likelihood of persistent concussion symptoms and a higher likelihood of PTSD. They seem to feed on each other. This is a study out of the Fanslow lab, which we work closely with from about 10 or 15 years ago, that showed after a fluid percussion model of traumatic brain injury, there was enhanced fear conditioning, basically, Maxine Rieger paired a foot shock with an auditory cue, and brain injured rats tend to overgeneralize that learned fear to both condition but also novel stimuli. And so again, we see this significant avoidant behavior in our patient population, a lot of fear, and we know that that leads to worsening symptoms. We need to be aware of that. But it turns out it's not just fear and anxiety. So this is Ann Hoffman. She works with us in BrainSport as well as the Fanslow lab here at UCLA. And she showed similar model, fluid percussion injury model in rats. And she paired an auditory tone with a foot shock. And again, these animals tend to overgeneralize to that auditory tone, but also even to white noise. And what she found is that there was this increased activity in the neurons that were projecting from the auditory part of the thalamus, the medial geniculate nucleus, to the amygdala. So not just enhanced fear conditioning, but maybe altered sensory processing, that the subcortical sensory emotional circuitry is abnormal, which results in normal sensory stimuli developing aversive properties. And this, again, really makes sense in our patient population. We see a lot of light sensitivity, a lot of sound sensitivity, patients coming into my office with dark sunglasses and earplugs in at a really greater degree than we see in other primary headache disorders. To me, that makes it difficult actually to differentiate in these patients how much of their sensory sensitivities are because of their post-traumatic headache. Is it migraine-like symptomatology, or is there something else going on that's a different downstream effect of traumatic brain injury? And so I really think we need to focus on that and start learning about this. We have started utilizing a lot of sort of exposure therapy in our patients to try and retrain them that sensory input is okay. And one of the new, not that new anymore, but kind of the I think upcoming still frontiers of neurology in general is autonomic dysfunction, and that's certainly the case here in concussion as well. And so dysregulation of the autonomic nervous system is common acutely and in PPCS. And in theory, this may have to do with some of those changes to altered cerebral autoregulation, resulting in a misbalanced sympathetic and parasympathetic tone. I think we're still working out how much is from the acute injury itself versus related to the consequence of the symptoms. So we know that anxiety and pain increase levels of autonomic dysfunction. We also know that pain and its kind of surrounding issues around the injury can increase anxiety. And then we know that anxiety and autonomic dysfunction end up in this loop feeding on each other. And so we like to focus on both. We like to treat anxiety in our patients with psychotherapy and that cognitive restructuring and reassurance and at times medications. And we want to treat their autonomic dysfunction with parasympathetic activation through breathing training, occasionally using medications, either with by ourselves or with the help of cardiology, and when possible, exercise therapy to improve that autonomic tone. And then lastly, we see a lot of cognitive dysfunction after concussion. I focus on headache, and yet a lot of my patients come in and say, I don't care so much about my headache. I could live with a headache every day, but it's that my brain just doesn't work since my concussion a year ago, that I go into rooms and I can't remember why I went in there. I forget people's names. I just can't remember anything, that my memory is gone. And if you narrow it down, it doesn't tend to be a memory issue. It tends to be a concentration and attention issue, a registration issue. And we know that we see the same dysfunction in our patients with bad migraine, with sleep dysfunction, with polypharmacy, with mood disorders, with anxiety disorders, with chronic pain in general. We know from the neuropsychological field that chronic pain and pain catastrophizing increase executive dysfunction. There's this term cogniphobia, where if a patient knows that when they exert themselves mentally, they will get a headache, for example, that's true for other things, not just headache, then their brain almost puts a brake on their cognitive function, and they actually have lower performance on memory testing. And so if we treat these underlying risk factors, treat their depression, anxiety, treat their chronic pain and headache, generally their cognitive dysfunction goes away. We use a lot of neuropsychological testing to reassure patients and to investigate that there's no objective dysfunction, that there's not an underlying learning disorder or neurodegenerative disease as a result of their traumatic brain injury, and that a lot of times they have totally normal neuropsych testing or executive dysfunction that we can attribute to other symptoms. Sometimes it's more of a subjective cognitive impairment that objectively they look great, but they just feel this brain fog. And I think some of that is an effort issue, that it's just more effort to think when they feel like this. But there may be a sensory component to that also, that maybe some of brain fog we think might be, say, even a vestibular symptom or a symptom of dissociation in patients with migraine and post-traumatic headache. So in conclusion, I want you to remember that acute concussion physiology generally lasts less than a month. That clearly acute and persistent traumatic brain injury symptoms are related to somewhat different physiology. That acute post-traumatic headache likely shares physiology with concussion in terms of the metabolic dysfunction that we see after the injury, but also related to elevation of headache-related pain neuropeptides like PACAP and CGRP. And that animal model showed there's a difference between acute and persistent post-traumatic headache, and we may need different treatments in those two time periods. And while the evidence is less so there in persistent post-traumatic headache, we do think these pain neuropeptides that we're learning so much about these days are playing a large role, but maybe not everything. So utilize evidence-based therapies, but recognize that we have limitations to our evidence, and sometimes we need to treat patients a little outside of the box. Use a lot of use your team, use a multidisciplinary approach PT, OT, psychotherapy, and neuropsychology are really important in this population. And again, teach your patients to avoid avoidance. I hope to have some answers in the coming years. I'm lucky enough to be part of a multi-site consortium called Care for Kids. It's a longitudinal study of concussion recovery in adolescents, late adolescents. It's a 5-year study. The first half is what we're calling the discovery cohort, where we have a large amount of imaging and serum biomarkers and neuropsychological testing and headache questionnaires to try and identify who is going to have persistent symptoms. We use longitudinal phone apps to keep track of symptoms, and then we check in with them and repeat all these studies, not just at month 1, but also at month 3. And we're happy to say we just finished the discovery cohort, and we'll be launching what we call the validation cohort, where we're going to nail down which part of this testing was the most important for predicting who will have persistent symptoms and who we need to intervene on early. And if there are certain, what we're calling endophenotypes, certain population groups that look differently, both in terms of biomarkers and also symptomatology, that can guide us, not just for prognosis, but for treatment. So I hope to have some more answers in the next few years, and I think this is a really exciting time for our field. And on that note, I want to say thank you for having me this morning, and I'm here for any questions that you have.
Thank you, Dr. Kamins, so much for that wonderful talk. We all learned so much today.
Pleasure.
I'm not seeing any questions yet, but I do have a couple of questions for you for myself. I find that in a lot of my concussion patients, especially if they've had whiplash injury, the neck pain tends to be very refractory to treatment, especially with medication treatments. What process do you use? What type of medications or other therapies do you find to be most helpful?
Yeah, I totally agree. I think the neck is a big missed part of the concussion world, and I'm happy to say that in our Care for Kids study, we had the research assistants learn how to do a neck exam, and I'm hoping to identify how many patients have occipital nerve radiating pain, myofascial pain, and neck pain as part of what they have. Physical therapy, I think, number 1, and I tend to try and get them in early for the neck. And actually, I think the neck sometimes plays a role in some of the dizziness and other visual dysfunction that these patients have too. A lot of occipital nerve blocks, trigger point injections. I'm a little more interventionally inclined, so I use ultrasound to do ultrasound-guided trigger point and tendon injections personally. And then not shy, at least in the adult world, to refer to interventional pain colleagues for medial branch blocks and radiofrequency ablations, because the facet joint can take a big brunt from the whiplash injury. In terms of medications, I think that's one of the reasons I tend to use tricyclics and the SNRIs more in this population than in my migraine population, because at least you get a little more pain benefit from those medications. And so, yeah, I have a lot of patients where I'm providing medication appointments and then occipital nerve blocks and trigger point injections every 6 weeks for the first few months after their injury, because I totally agree it's a big part of it.
I guess I'll just keep asking questions.
Sure.
You mentioned some of the autonomic features. Can you expand a little bit on that and what particular treatments you found to be most helpful for those features?
Yeah, we see a lot of essentially what we just call POTS, right? Orthostatic tachycardia. And even in my non-TBI patients, I find POTS is often a secondary disorder. They have chronic pain or chronic anxiety, and that results in this imbalance between the sympathetic and parasympathetic outflow. And so treating their underlying symptoms is really important. And then in addition, in the concussion world, you have a lot of deconditioning, patients that are used to be athletes and suddenly aren't doing anything. And so it's a combination. One is getting these patients moving again, teaching them to, like I said, push into their symptoms a little bit so they can become more physically active again. Avoiding certain medications that can exacerbate POTS and autonomic dysfunction, like tricyclics, most importantly. And then referring to cardiology at times. Well, I'm happy to institute beta blockers, but for more advanced treatments, like Corlinor, for example, you might need to involve cardiology. I also think that it's something that we're probably underdiagnosing still. We have these really specific diagnoses like POTS, and we need specific criteria like your heart rate has to go up by 30 points when you stand up. But I do think that some of this brain fog and some of these other symptoms may be another version of autonomic dysfunction, that they're overactivating their brain when they try and use just a little bit of it, and that this leads to increased fatigue and cognitive dysfunction. And so I'm hoping that there are better tools in the near future. In the CARE study and a bunch of other studies, they're looking at things like heart rate interval and respiratory rate, pupillary changes, because I think we need better tools to identify these patients with autonomic dysfunction, with sympathetic hyperactivity or parasympathetic reduced activity. And then hopefully once we have better tools for diagnosis, we can develop some better tools for therapy as well.
Well, thank you again so much. It was a pleasure to have you.
Sure. Thank you so much for having me this morning. Have a nice rest of your day.
You too. Thank you. Hope to see you at the next AHS conference.
Sounds good. I'm on the committee putting on the Scottsdale conference, so I have to be there. So I'll see you there.
Great. We'll see you in December.
It sounds good. Have a nice day.